the car. Call the meeting of the Health Subcommittee to order, and today we're having a hearing on cutting waste, fraud, and abuse in Medicare and Medicaid, and I'll recognize myself initially for an opening statement. What we're doing is examining how the Department of Health and Human Services is using available statutory tools to reduce waste, fraud, and abuse in the Medicare and Medicaid programs. While estimates of the total cost of healthcare fraud are difficult to obtain, it's estimated that all healthcare fraud costs patients, taxpayers, and healthcare providers billions annually. For every dollar put into the pockets of criminals, a dollar is taken out of the system to provide much-needed care to millions of patients, including our nation's most vulnerable populations, children, senior, and the disabled. Fraud schemes come in all shapes and sizes. We heard just last week in the subcommittee about how durable medical equipment companies set up sham storefronts and appear as legitimate providers. They bill Medicare for millions and then close up their stores only to find a new location and do it all over again. And then there are the legitimate businesses that bill for services that were never provided and pay kickbacks to physicians or street criminals trafficking in illegally obtained drugs. In the end, it all has the same result, undermining the integrity of our public health system and driving up healthcare costs. I think we can all agree that healthcare fraud is a serious, long-standing problem that will take aggressive, long-term solutions to reverse. We made a strong commitment to combat these issues when Congress passed and President Obama signed the Affordable Care Act earlier this year. That bill contained over 30 anti-fraud provisions to assist CMS, the OIG, and the Justice Department in identifying abusive suppliers and fraudulent billing practices. The most important provisions change the way we fight fraud by heading up the bad actors before they strike and thwarting their enrollment into these federal programs in the first place. And this way, we aren't left chasing a payment once the money's already out the door. Some other important measures in the legislation include significant funding increases to the Healthcare Fraud and Abuse Fund, the creation of a national healthcare fraud and abuse database, and new and enhanced penalties for fraudulent providers. CMS and OIG have important roles to fulfill, and along with the Justice Department and state and local Medicaid programs, they're better equipped today because of the Affordable Care Act to safeguard the health and welfare of Medicare and Medicaid patients. I want to welcome Peter Budetti, a former staff member of this committee. I know that you're no stranger to these issues or our hearing proceedings. I also want to welcome, or special welcome to Daniel Levinson, who had the lucky privilege of being in front of this subcommittee just last week and joins us again today. I'm going to thank both of them again for their testimony. And I'll obviously like to thank our first panel, Representative Ron Klein and Representative Peter Roskam, for joining us today. Your participation basically illustrates the importance of this issue within the Congress, so we look forward to your testimony on the first panel. But now I'll recognize my ranking member, Mr. Shimkus, for an opening statement.
Thank you, Mr. Chairman. We have long struggled with combating the issue of waste, fraud, and abuse in the Medicare and Medicaid debate. Criminals take billions of dollars out of the system that could be spent on patient care and reducing costs. And with entitlement programs growing at an unsustainable rate, we simply cannot afford to let these taxpayer dollars go to waste any longer. I'm glad to see the progress that HHS and the Department of Justice have made in recent years, with additional resources, but we can and must do more. Thanks to the efforts from our colleagues, Mr. Klein from Florida and my good friend Peter Roskam from Illinois, attention remains on new innovative ways for improving the system. In Peter Roskam's case, H.R. 5546 addresses an issue that I've talked about in the committee a long time, is addressing the issue prior to sending the checks. That's what we do a very poor job at. We'd rather address the issue before the money goes out the door than trying to gather up the dollars after they've gone fraudulently to places for years, numerous years. And so that's why I'm very excited about it. And I know that Peter has done a good job engaging the administration and has received some pretty good feedback from the administration. We all know he's a close friend with the president and former Illinois Senate buddies in the days gone by. This also, and from Mr. Levinson, I apologize so he gets a chance to hear my rant and rave about the inability to get the Secretary to testify before us on the health care law We're now close to 6 months. I guess 6-month anniversary will be tomorrow. She's already engaged in the debate on premium increases, and I think now would be the time to bring her to the committee, Mr. Chairman, so we can have a full and fair and free debate about the good and the bad and the ugly on the health care law and move in a direction to try to fix some of the major provisions. We know the high-risk pools are at risk themselves. We know premium increases are going up. We know the cost curve was not bent down, but it's bent up. We will continue to raise these issues until we all leave for the election break, which we're trying to figure out when that might be. Thank you for this time. Before I yield back, I think they've been shared with your majority staff 4 letters for submission to the record that I asked unanimous consent to insert.
Without objection, so ordered. I'm shocked that you're actually handing me paper now that I see your computer device there that you use.
I'm trying to be as cool as you, Mr. Chairman.
Okay. Without objection, so ordered. And I'll now recognize the chairman of the full committee, Mr. Waxman.
Thank you very much, Chairman Pallone, for calling this hearing, and I'm pleased to welcome our 2 colleagues who've introduced legislation. We all want to stop Medicare, Medicaid, waste, fraud, and abuse. Those of us who support those 2 programs, and we know that millions of Americans rely on them, want to make sure that the money we spend for Medicare, Medicaid services are going for those services and not for waste, fraud, or abuse. This is an important hearing. The Medicare and Medicaid programs, if there's fraud against them, they're bilking taxpayers and they're undermining public health. And whether it's a street corner criminal illegally trafficking in pharmaceutical drugs or a large multinational corporation paying illegal kickbacks to health providers, the bottom line is the same. Billions of dollars are stolen from the taxpayer-funded programs that provide health care to seniors, children, and the disabled. This kind of fraud costs more than money. It corrodes the quality of care. It weakens Medicare and Medicaid. And I must say that I've heard from providers over the years that a lot of them feel that trying to figure out how to game the system becomes very much part of what they do because everybody else is doing it. It's a rationale that isn't very comforting when we hear it from our kids, but I've heard it over and over again throughout the years. We want to hear from the administration, and I'm glad that Mr. Bedetti, who once served on the staff of this committee and the Oversight Committee when I chaired it, is here to talk about the administration's effort, as well as Mr. Levinson, who is the Inspector General at HHS. You both play a very important role in combating waste, fraud, and abuse. I hope this hearing today will lead to a greater commitment and realistic provisions to stop the fraud, waste, and abuse before it takes place, not try to wait till afterwards to collect the money back. Thank you, Mr. Chairman. Yield back my time.
Thank you, Chairman Waxman. Next is gentleman from Georgia, Mr. Gingrich. It's nice to see so many members here today. I was afraid that since we didn't go in until this evening, we wouldn't get that many, so it's good to see so many.
Mr. Chairman, I'm glad to be here. Each year, at least 3% of our country's annual health care spending, that would be $68 billion, is lost to fraud. In fact, the FBI estimates that the number is much higher, as much as 10%, or $226 billion. So clearly, this is a problem in need of a fix, and an immediate fix, if at all possible. On the one hand, I'm pleased to see that Medicare fraud is not a partisan issue. For the members who will testify here today before us, both Republican and Democrat, they symbolize that bipartisan interest, and I applaud them for their efforts, both Representative Klein and Representative Roscommon, and we look forward to their testimony on their specific bills that they've introduced. American taxpayers deserve to know that their money is being safeguarded here in Washington, and preventing Medicare waste, fraud, and abuse is one way to protect their precious resources. While I may support many of these efforts to curb Medicare waste and fraud, including in Obamacare, Patient Protection and Affordable Care Act of 2010, of March 23rd, it's unfortunate that these provisions were enacted in a bill that I think is proving so harmful to both patients and businesses here at its 6-month anniversary. The legislation promised to reduce the cost of health care on patients by an average of $2,500 a year. This, some proponents argue, was worth the cost of turning our health care system over to the federal government and spending almost $1 trillion in the process. The bill proponents spent about 18 months blaming insurance companies for the high cost of care, and they told the American people that Obamacare could fix the problem. Here we are, 6 months later, and insurance costs are going up by as much as 20%. The reason for these increases? Patient Protection and Affordable Care Act of 2010. I have asked this committee repeatedly to call a hearing in order to find out what in the world is going on. To support this request, Secretary Sebelius has taken the unusual step of publicly denouncing these costs as she says, unjustified rate increases. If that's the case, Mr. Chairman, then I believe that the Secretary should come before this committee and explain her reasons. The American people certainly deserve answers. Another promise was that every American would have health care if the bill was passed, which when you read the fine print means the federal government can now tax and penalize any American who doesn't buy insurance, regardless of whether they have the ability to pay for it. With 6-month anniversary of Obamacare tomorrow, I think it's safe to say the early news is not good. The 18 months the President and your majority, Mr. Chairman, spent on selling Obamacare instead of getting people back to work has not only left many Americans without jobs, but with higher health care costs as well. Put simply, Obamacare has proven to be no way to solve a health care crisis. Mr. Chairman, with that, I'm going to yield back. I do look forward to both panels, and thank you for calling this hearing.
Thank you, Mr. Gingrey. Next is the gentlewoman from Colorado, Ms. DeGette.
Thank you very much, Mr. Chairman. Mr. Chairman, I think I never met a politician who believed in waste, fraud, and abuse, and I think that it's great that we're having this hearing on how we can continue efforts to cut waste, fraud, and abuse in Medicare and Medicaid. I frankly can't believe that actually we're having such partisanship in some of these opening statements, because I think we can all agree on a bipartisan basis that we should eliminate waste, fraud, and abuse. And as proof, we have 2 of our colleagues from both sides of the aisle here to testify this morning. Eliminating these issues is an important goal, and it sounds like it should be easy to do, but in fact, these fraudulent practices are becoming increasingly more sophisticated. And what I'd like to do today is really sit down and talk about how we can put together sophisticated responses to address this sophisticated fraudulent practices. Let me give you an example. In Denver, we had a woman who was arrested by the HHS DOJ strike force in 2009. It was a nationwide sweep that involved Medicare, a Medicare kickback scheme in Michigan. So the woman was from West Virginia. She was arrested in Denver for a kickback scheme in Michigan. And this is the level of sophistication that we're dealing with this fraudulent activity. This is why we really have to put together some sophisticated responses. I'm looking forward not just to hearing from our colleagues today, but also from the experts who can talk to us about really what we can do to actually cut waste, fraud, and abuse instead of just talking about it in election year. And I'll yield back.
Thank the gentlewoman. Next is the gentlewoman from Tennessee, Ms. Blackburn.
Thank you, Mr. Chairman. I thank you for the hearing, and it is an important issue, one that we need to focus on. I welcome our colleagues, and I want to especially commend Mr. Roscom for a bill that takes a proactive approach and looks at how we address this issue before the payments are out the door. I think that's important. You know, one of the things we have to realize when we look at the Medicare component of this is that our seniors have prepaid their access to Medicare. The government's been taking that money out of their paycheck for years. And they do expect to get the services that are there. And Mr. Waxman and I actually agree on something which may surprise some of you who are regular attendees in this room. And we have to make certain that we look at the delivery systems but that the services are there for the people who are entitled to those services, to our nation's seniors. The Medicaid component of this, I would like to highlight with this committee that in 2003, we did a field hearing, one of the first field hearings on Medicaid fraud. This was in Bartlett, Tennessee. It was done on the TennCare program, and many of you have heard me talk about TennCare, which was the experiment for the Clinton healthcare program, for Hillary Clinton's healthcare program in the preamble to Obamacare. What we found was rampant waste, fraud, and abuse in this program, so much so that TennCare has its own investigative bureau in trying to capture and quantify and then recapture those dollars. So it is a program. It's a problem, and we know it is a problem. I want to say a little bit about Obamacare, since this is the 6-month anniversary of that passage, and I think that right now we are beginning to see the aftermath, or maybe it is the lack of math, if you will. The law is costing Americans and families with children undue hardships and is a financial burden. We're beginning to see this. There has not been a single oversight hearing in this committee. There is no transparency in the budgetary operations and processes. Americans are losing coverage. They're losing patients. Our focus needs to be turned to that. The real cost of Obamacare goes much deeper than the government's pockets. We're seeing estimates that it's going to cost hard-working citizens who are hanging onto their jobs on average $899 per year in premium contributions, an increase of more than 15% than last year. The percentage paid by workers for individual and family coverage rose for the first time in over a decade. Individual premiums average over $5,000 and family premiums average nearly $14,000. Additionally, Obamacare will lead to a 51% reduction in current health coverage for the American workforce over the next 3 years. To keep American workers employed and healthy, this is an absurd statistic. 9 regulations are included in the healthcare reform that will in fact raise premium costs for individuals and employers. These facts are alarming for a country facing uncertain times and economic hardships. Prominent health insurance have even stopped issuing. They are stopping issuing the child-only plans instead of meeting the new requirements of accepting children with pre-existing conditions. What happened to the promise that if you like what you have, you can keep it? Now the most vulnerable are losing their coverage. We should be focusing on this. There were a lot of lessons to be learned from TennCare. We in my state have been down this road. Mr. Chairman, we need to be putting some oversight and some attention on this. I yield back.
Thank you. Next is the gentleman from Texas, Mr. Gonzalez.
Mr. Chairman, it's not my practice generally to make opening statements, but I'm going to have to agree with Ms. DeGette. We can take up an hour on campaign rhetoric. I would simply like to reserve that for the time that we're not trying to conduct hearings and listening to witnesses. We can go back and forth. The truth is, the health care bill passed. Its major provisions will not take effect for another couple of years. If anyone on the other side of the aisle wants to basically rescind what is already taken place and the benefits that are being enjoyed by millions of American families, then say so. Don't speculate on what may or may not happen in a year, 2 or so. But what about the immediate benefits? Do you really want to deny families the ability to obtain health insurance for their child who may have a pre-existing condition? Do you really want the insurance companies to be able to rescind your policy when you get sick? Those are the benefits. And, we'll go on and on with this. The only thing is I'm hoping that we can get to something, an issue that we should all have some concurrence, and that is not letting the taxpayer of this country lose money due to fraud. And with that, I yield back.
Thank you. Next is another gentleman from Texas, Mr. Burgess.
Thank you, Mr. Chairman. course, it is my policy to make opening statements in this committee, and I will do so. I don't think the federal government has done enough to address the issue of inappropriate transfers of funds for several years, even as reports indicate that our nation's government-run systems needlessly waste hundreds of billions of dollars each year through these activities. So eliminating the problems that cause the hemorrhage of billions of dollars in our country's government-run healthcare programs should have been a priority actually before we began to think about expanding the role of the federal government in healthcare, but we didn't do that. Fraud analysts and law enforcement officials that estimate that 10% of the total healthcare expenditures are lost to fraud on an annual basis. If we are serious about bringing down the cost of healthcare and protecting the patient, but not just reducing but eliminating fraud is where we need to go. In Medicare, the government pays providers in practically an automatic fashion without review or scrutiny of the claims submitted. In North Texas, Fox 4, Channel 4, Becky Oliver, an investigative reporter, reported on a home health agency operator who's now behind bars. The records show that Medicare paid her over $8 million in 2 years' time to care for homebound patients. The woman's patients included a man seen moving furniture, a lady seen running errands, and a man seen enjoying barbecue. Even worse than that, she had multiple provider numbers, and after they shut down one provider number, they continued to pay other provider numbers to the same post office box. This is unacceptable. Currently, the Center for Medicare and Medicaid Services oversees a network of private contractors that conduct various program integrity activities in conjunction with the Office of Inspector General at Health and Human Services and the Department of Justice, yet we're still losing billions of dollars annually to fraud. We must improve oversight of these contractors, and the Center for Medicare and Medicaid Services needs to take a more proactive role in assuring that contractors are using the utmost scrutiny in reviewing their activities. Further, I will raise a point that I've raised numerous times. How much fraud are we willing to tolerate? And the answer should be none, but in reality, the lack of prosecutors with a background in health law cripples our ability to go after everyone, or in fact, anyone. Are we comfortable with that? And if not, this committee should work with our colleagues in judiciary to correct it. Under the Patient Protection and Affordable Care Act, and I would submit that affordable should be stricken from the title, but our current system is to prevent improper payments, and we know it's inadequate. How can you assure that millions of dollars in funding in the PPACA and the Reconciliation Act will solve the problem? If more needs to be done, and it does, it should be a priority in this committee. I have introduced several fraud-fighting amendments during the consideration of our health care bill 3200. As a ranking member of Oversight and Investigations, I'm working with Ranking Member Barton to build off these suggestions for forthcoming legislation. As healthcare expenditures continue to rise, developing new and innovative approaches to fight fraud become increasingly important, and I look forward to the testimony of our colleagues today, as well as the representatives of the federal agencies, and I'll yield back.
Thank you, Mr. Burgess. Next is the gentlewoman from Florida, Ms. Castor.
Thank you, Chairman Plum, very much for calling this hearing, and I'd like to welcome my colleagues, Congressman Roscom and Congressman Klein. Ron Klein especially has been a real leader for our Florida delegation when it comes to Medicare and fighting fraud, and rightfully so, because South Florida often has many shady dealers down there. So Ron, thank you very much for your terrific leadership on the issue. In Florida, Medicare and Medicaid is a real lifeline for our families and our seniors. Folks simply expect that the folks in charge of administering these initiatives keep a close eye on fraudulent practices. And I think we're going to continue to improve when it comes to that. I'm also very sensitive to the issue. Just in 2007, the FBI raided a major health insurance company in Tampa, and that provider had stolen over $600 million from Medicaid and Medicare through fraudulent claims to CMS and ripping off the state of Florida. Subsequent to that, the Obama administration thankfully cited one of their new healthcare fraud prevention and enforcement teams, the HEAT teams, in Tampa, and our local U.S. Attorney's Office is very appreciative of the new tools that will allow us to continue to weed out these fraudulent practices in Medicare. I'm also very optimistic over the new robust commitment to anti-fraud in the Affordable Care Act. The Affordable Care Act clearly outlines a strategy to combat fraud in Medicare and Medicaid, and these new tools are really going to help us prevent shady practices and recoup billions of dollars that rightfully belong to the health services of families across the country. So this is a good news week when it comes to health care, because not only are we going to highlight the robust new commitment to weeding out Medicare fraud, we can celebrate a lot of important consumer protections that are taking effect just this week. No longer will health insurance companies be able to say to families with children with diabetes or asthma that they can't get coverage. That's fundamental in this great country. Also, I know many of you are hearing from families like I am back home. They are so appreciative that kids can stay on their parents' insurance policies until the age 26. That takes effect this week. This week, the law will prevent health insurance companies from canceling coverage when you get sick or if you made a mistake on your application. And one of the things we've been fighting for years is a new emphasis on wellness and preventative care. And this week, families across America will receive their preventative care without having to pay significant out-of-pocket expenses for services like mammograms and colonoscopies, immunizations, and prenatal and well baby care. This is something we've been working on for a long time that's going to help us save money just like fighting Medicare fraud will. Also on Monday, I hope you saw Blue Cross and Blue Shield announce that thanks to the Affordable Care Act, over 200,000 customers will receive refunds totaling over $150 million. And just yesterday, we learned, and Congressman Klein is going to like this because he's been such a champion for making sure Medicare Advantage works. We learned yesterday that on average, premiums for seniors enrolled in Medicare Advantage will decrease. So this is a good news week when it comes to health care. And again, thank you, Mr. Chairman, for convening this hearing. I look forward to hearing from our witnesses.
Thank you. Gentlewoman from, do you want to? A gentlewoman from the Virgin Islands, Ms. Christensen.
Thank you, Chairman Pallone, for this hearing where we get a chance to focus on the improvements that the Patient Protection and Affordable Care Act is making on reducing waste, fraud, and abuse in CMS programs and potentially all government-run health care programs. The willful fraud and abuse and the waste that we often see in these programs cost not just the taxpayers, but all who depend on the system for care immeasurable damage. And the savings that will be realized from reducing or eliminating them will serve to improve and expand services to the beneficiaries and others. I also want to thank my colleagues, Congressman Roskam and Congressman Klein, for their legislative offerings to make the Affordable Care Act provisions even stronger. As a physician who struggled with it, then HICFA, I have to say that also an important part of the CMS armamentarium ought to be fair and adequate reimbursement. And the Affordable Care Act does make some important steps in that regard. As a provider physician, I also want to thank both the Inspector General and the Deputy Administrator for including a statement, either this particular statement or one similar, that the vast majority of health providers are honest people who seek to do the right thing and provide critical care services to millions of CMS beneficiaries, and I would add others every day. Too often, that's not the message that we hear or the premise that guides legislation. It is a daunting task or set of tasks that the law has set out and you have before you. I am glad that you see providers as well as beneficiaries as your partners, and the key here are clear guidelines and appropriate education on how we can best be that. These and all of the other provisions of the Affordable Care Act provide a strong blueprint for turning what, despite all of the wonderful technological, pharmaceutical, and biotech advances, is a dysfunctional and inequitable system into a world-class system that would be the envy of the world. I look forward to all of the testimonies and the discussion to follow, Mr. Chairman, and I yield back the balance of my time.
Thank you. Next is our Chairman Emeritus, gentleman from Michigan, Mr. Dingell.
Mr. Chairman, thank you. I want to commend you for this hearing. The topic before us is a very important one. Each year, the taxpayers are losing billions of dollars because of intentional fraud to the Medicare and Medicaid systems. Criminals who defraud these programs not only steal from the taxpayers, but they do it at the expense of American seniors and families. The administration has taken many positive steps to fight fraud. This committee has been immediately involved in many of these, and the fight goes back a long way. These actions show why it is a very much needed government action. My people in Michigan have seen firsthand the work of the Medicare Fraud Strike Task Force. Their work led in July to arrests of 94 people who had defrauded the Medicare system. 2 of these scam artists were from Detroit and were convicted in a $2.3 million fraud scheme. These people not only broke the law, but they took advantage of the most vulnerable members of our society, the elderly and poor, and they harmed programs that are vital to that particular community and to this country. This is only a beginning, and the health care reform law does a number of good things, but some of the lesser-known benefits of it included the unprecedented set of tools it gives the administration to squeeze out waste, fraud, and abuse. Because of the Affordable Care Act, the administration can now move from a pay and chase model of fighting fraud to a much better one. One that prevents fraud from happening in the first place. Now criminals will not be accepted into these programs in the first place, and those that slip in will not get paid. For example, the new law requires stronger rules and sentences for people who commit health care fraud, better screening tools to prevent fraud from happening, requirements for providers and suppliers to establish plans on how they will prevent fraud, and enhanced data collection that allows CMS, Department of Justice, and the states and other federal health programs to share information. The new law does something else that is also important. It creates enhanced oversight of private insurance abuses. Waste, fraud, and abuse are not confined exclusively to Medicare and Medicaid. In fact, some of the most egregious examples of waste of beneficiary dollars happen in the private sector. Beginning tomorrow, it will be illegal for insurance companies to rescind policies once a person gets sick. Children with pre-existing conditions can no longer be denied coverage. Young adults up to age 26 can remain on their parents' health care plan, and lifetime limits on health care coverage will be a thing of the past. Furthermore, insurance companies will be required to publicly disclose and justify minimum increases, and they will have to provide rebates to customers if their non-medical costs exceed 15% of the premium cost in the group market or 20% in the small group and individual market. Despite all the doomsday predictions that we have heard during the healthcare reform debate, these waste, fraud, and abuse provisions are proof that the new law is working and is in the interest of the American people. Mr. Chairman, again, I thank you for recognizing me, and I commend you for your leadership in this matter and yield back the balance of my time.
Thank you, Chairman Dingell. Our next member for an opening statement is the gentleman from Iowa, Mr. Braley.
Thank you, Mr. Chairman. Since I joined this subcommittee, I've been focusing on the importance of addressing the enormous problem of waste, fraud, and abuse, not only in Medicare and Medicaid, but also in the private sector, as the Chairman Emeritus noted. The problem of fraud gets the lion's share of public attention, and that 60 Minutes program on October 28th of last year is a good example of that. It showed people who were leaving careers as drug dealers in Florida because they could make more money in Medicare fraud. And they talked in that program about the enormous financial cost of Medicare fraud, and they used the figure of $60 billion a year. But the real elephant in the room, pun intended, is the problem of waste in healthcare delivery. And one of the most important books ever given to me was by a doctor in Cedar Falls, Iowa, named Jim Young, and the book is Overtreated by Shannon Brownlee, Why Too Much Medicine is Making Us Sicker and Poorer. And in this groundbreaking publication, she cites many healthcare researchers, including many medical economists. And she speaks specifically of the work done at the group at Dartmouth Atlas, where they estimated that as much as 30% of medical care paid by Medicare as well as private insurers is useless, unneeded, a waste. Quote, as of 2006, when the total healthcare budget reached $2 trillion, Americans were spending as much as $700 billion a year on healthcare that not only did them no good, but caused unnecessary harm. And one of the biggest driving factors in this waste and overutilization problem is the provision of unnecessary care. And one of the biggest problems we have is the enormous cost of prescription drugs in this country. Americans consume about $200 billion worth of prescription drugs a year, and it used to be that the drug industry itself advocated against direct-to-consumer marketing. In fact, our chairman emeritus held hearings on this in 1985 and had the leading pharmaceutical manufacturers testify in response to his questions, and they were on record as saying direct-to-consumer advertising would make patients extraordinarily susceptible to product promises. We believe direct advertising to consumers introduces a very real possibility of causing harm to patients, and advertising would have the objective of driving patients into doctors' offices seeking prescriptions. Guess what? That's exactly what's happened, and the drug industry has completely changed their position on direct-to-consumer and direct-to-physician marketing. So we have an enormous challenge, and that's why I commend both of my colleagues. We need to make this a bipartisan focus of our work in Congress, because the American taxpayers can't afford to continue to sustain wasteful and fraudulent spending with their tax dollars. And I yield back the balance of my time.
We thank the gentleman, and I think our last member is the gentleman from Texas, Mr. Green.
Thank you, Mr. Chairman. Hearing so many opening statements, I really don't. My opening statement's basically the same as other members. None of us support fraud or abuse in the Medicare, Medicaid programs. It's so important to our constituents to have this option. But following my Republican colleagues, I'd say, in 2003, a number of us on our side didn't vote for the prescription drug bill because of the flaws in it. But I don't remember us saying we were going to defund it. We wanted to fix it. And there are things I'd like to fix in the health care bill that I would hope we could work across the aisle and do it. But to start out every hearing we have on trying to deal with health care, to say how that the health care bill that's now the law, it's the law of the land, and we're going to work to make it happen, because it's been something that's been needed for at least my whole lifetime. So with that, Mr. Chairman, I'd like to place my full statement in the record and look forward to hearing from our witnesses.
Thank the gentleman, and any member who seeks to put their statement in the record is certainly entitled to do so, and so ordered. Well, now, I think we've heard from all the members, so we'll now go to our witnesses. In our first panel, of course, the congressional panel, we have the Honorable Peter Roskin from Illinois and the Honorable Ron Klein from Florida, and I appreciate you taking your time today to appear before us, and I guess it shows us this is an important issue, the fact that you're here. So we'll start with Congressman Roskin.
Thank you, Mr. Chairman, and Ranking Member Shimkus. I really do appreciate the opportunity to just spend a couple of minutes with you. I want to tell you a quick story. 10 years ago or so, my wife and I were traveling overseas, and I decided to save a couple of bucks, and we were going to take the subway in Budapest, which upon reflection is a very foolish thing to do. So I'm in a Budapest subway, and I get pickpocketed. Now, from the time that I got out of the subway to the time I got back to the hotel room, I had gotten a notice from the credit card company that said, there's $10,000 that is poised on your card. Did you buy stereo equipment on the street an hour ago? And of course I didn't, and they shut it off. Now, Chairman Pallone in his opening statement said a phrase that I think really encapsulates this whole drama, and the question is, he said, what we need to do is to concentrate on heading off bad actors before they strike. Now, I understand the drama, the back and forth about the current health care law. One of the things that I think that is in the current health care law that is a gesture in the right direction, even though I opposed it, is some of the things, some of the anti-fraud elements of it, some of the enhanced penalties and so forth. And that's an area where there's really a lot of common ground. My hunch is that based on these very, very large numbers that we're talking about, that we need a larger gesture. And let me walk through a piece of legislation that I have introduced. It got, sort of a favorable mention by Nancy Ann DePearl in the White House. We had a good conversation and meeting about it. It was in President Obama's outline that he sent up to the Hill. It didn't make it through on final passage. But I think it's an area where there's a lot of interest and a lot of common ground. And even with meetings that I've had with HHS, I haven't sensed a defensiveness. It's more a sense of, well, how do we actually implement something like this, and how do we go about doing it? Let me just go back one quick second. The administration reports that about a little over 7%, or $24 billion in improper payments in Medicare fee-for-service is paid out. And that's sort of in the range of all of your analysis that you've been talking about. But I think there's a weakness in the analysis in that it's really only looking at overpayments and underpayments. It's not looking at the type of fraud that you were all addressing in your opening statements. So I think the president, to reach this goal that he set out, which is an excellent goal of cutting fraud in half by 2012, he's going to need more tools, and I think that we can help to get more tools. The increased data sharing, some of the things that Mr. Dingell mentioned, the reorganization of program integrity efforts, greater compliance efforts, additional funding for enforcement efforts. Every dollar that goes in on the enforcement side comes out as about $17 saved. So this is an area that is ripe for investment. But my bill is H.R. 5546, which is called the Fighting Fraud with Innovative Technology Act, and it uses this predictive modeling. And essentially, it doesn't wait for the bills to go out the door, but it uses the same type of technology that the credit card companies have used. Let's put this into context. Credit card companies right now, within the global economy, there's $11 trillion of credit card transactions every year. Just let that number sink in for a second. The type of fraud that they're dealing with is 0.047%. Contrast that with the type of numbers that we've been talking about this morning, on the order of 10%. Okay. CMS currently uses a limited application of prepayment screening, editing, and selective review of claims conducted by Medicare administrative contractors. Most resources are utilized on post-payment review activities by zone program integrity contractors and recovery audit contractors. But the fraudsters continue to be one step ahead of our current rules and edits-based automated claims processing. Predictive modeling, this approach, can detect fraudulent claims that traditional rule-based edits simply can't identify. CMS is currently developing an integrated data repository that will eventually contain all provider data that can be mined, but this will still be post-payment. Predictive modeling scores a claim to identify claims that have a high probability of fraud. A predictive model creates an estimated score on claims using historical data, and that estimate is then applied to new claims that are being submitted. The predictive model is always evolving, improving, and adapting to provider and patient behavior. So in other words, highly suspicious claims are subject to manual review to avoid false positives and to provide self-audit appeal process, which is encouraged. Following successful implementation to the Medicare program, you could contemplate rolling this out for other elements of federal health care claims. But my suggestion is let's creep and crawl and walk, and let's start with focusing in on Medicare. That's basically this bill in a nutshell. And my sense is that there's an opportunity for us to come together and to really to give the administration the tools they need, to give a whole host of folks the tools they need. Because the approach that we've taken up until now has just underperformed. And I think even in the healthcare law, there's things that are going to be beneficial from an anti-fraud point of view, but I think it's going to be beneficial on the margins. I think the heart of this is to change the entire paradigm. And to change that entire paradigm, we need to do the type of predictive modeling. And it's not like it's open field running. In other words, it's not as if this hasn't been tried and this is a fool's errand. This is something that has been tried and demonstrated. And I think toward that end, I'd submit my bill for your consideration as you're moving forward for possible solutions. Thank you.
Thank you. Congressman Klein.
Thank you, Mr. Chairman, and I'd like to thank the ranking member and Chairman Waxman and Chairman Emeritus, Mr. Dingell, for leadership in Medicare over the years as well. I join Mr. Roscom and all of you in trying to find some solutions to this big issue. The bill that I'm submitting for your consideration is drawn up with Ileana Ross-Lehtinen from Miami. It's H.R. 5044. It's called Medicare Fraud Enforcement and Prevention Act. As Ms. Castor mentioned, she and I both represent large areas of South Florida, and West Florida, which include large numbers of Medicare participants. And unfortunately, in particular, there have been large concentrations of Medicare fraud. You know the story about go where the money is, and this seems to be one of those areas that it absolutely follows through. I think we've all had constituents, and I can share with you the stories of constituents that come to my office with sheets of billing which are just outrageous. I mean, repetitive, false information, all sorts of things, and literally just pages and pages of the same services, in some cases billed over and over again. And I'm not suggesting this is the norm, but we know that there are lots of cases in the billions and billions of dollars which add up to this, and the question is why and how can we address it? I think we know it's deplorable for all of us to allow our seniors to be preyed upon by these criminals. And by the way, they're not all small-time criminals. There's organized crime behind this. It's large scale in this type of approach. We know that who loses from Medicare fraud? It's obviously the people who provide the services, whether they be doctors, hospitals, legitimate providers, people who are on the receiving end who want to get the best benefit for the dollars that they've contributed, and taxpayers. All of us are taxpayers. We're all paying in every year with the view that Medicare will be there for us. So in short, we are all losers when a criminal commits Medicare fraud, and we have an obligation to fight back. Our bill takes a comprehensive approach at attacking criminals who seek nothing more than ripping off Medicare, as I said, and preying on seniors. And the way we're approaching it picks up on some of the things that Mr. Roscom said. We had a chance to meet with a number of the strike force people down in Florida. We've met with the FBI, we've met with law enforcement, we've met with the Inspector General's office, we've met with the committee staff to try to really get a comprehensive view on what are the specific things that can be done. And what we've come up with are a number of things. Number one, on the law enforcement side, to make much more significant the criminal penalties for committing these acts. I mean, that's a very common sense approach here, but the slap on the wrist is unacceptable. Someone who's going to commit this kind of fraud, obviously it's fines and criminal penalties, but you know, for the same reason we know that many of the people who commit the fraud, many times they're gone. And those of us who live in areas where they're bordering other parts of the other countries, they're out of here. I mean, once they collect their checks, they're leaving the country or they're going somewhere else. So yes, it's good to have a deterrent factor in place and have a much more substantial way of setting out a deterrence of saying, if you do this, you will be in prison for a long time and you will pay significantly. That's appropriate, and that's part of this bill. But the second part of it is what we all know is the pay and chase issue, and that's what we've been talking about, and that's people get this Medicare provider number in a very simple way. The due diligence, the checking, the verification is unfortunately not what it should be. So what we've done is we have put a number of things in place in our proposal which gets to the point of providers and suppliers, before they can get their Medicare number and go off to the races, is having a much more thorough pre-screening measure through use of technology and a lot of other things. And this is the way to stay ahead of the criminals. Once they get the number, they're getting the checks. And even to the point where our bill makes it a much more significant crime to be a part of this whole process by selling your number to others. Or unfortunately in South Florida, we've heard of the cases where lots of senior citizens are getting paid to have their number used, and they're getting $20, $30, and obviously that individual number is being used for a significant multiplier. Another issue that we found is a flaw in the system are the unnecessary gaps in time when a fraudulent claim is submitted and when the law enforcement agency is alerted. That's a time squeeze that needs to be reduced down to nothing.
We met with the local Medicare administrative contractor for Florida, and although they told us they have some sophisticated computer system to check for anomalies, they only download this information once a week. Well, if you're only downloading it once a week, again, it goes to the point of credit card information. This isn't rocket science. This can be done. It can be done in real time. It's all technology based, and it can be done in real time. So again, it's just another specific solution to the problem. And of course, this whole notion of providing law enforcement with more resources, more personnel on the ground, I'm a big believer in this case to spend a little more money to save substantially more money, I think is an appropriate investment here. So these are some of the ideas in our bill that we'd ask you to take a look at. Time is of the essence. Every day that passes, millions more goes out the door into criminals' hands, and more importantly, it doesn't go to the people who need to provide those services and to the people who are paying for them. As we've said before, this is a bipartisan issue. I'm very proud to work with Ileana Ross-Lehtinen, Mr. Roscom, and many of you I know have already talked about in your opening statements, and you have lots of ideas from back home. So we look forward to working with you, Mr. Chairman, and the whole committee in working and creating some legislation, whether it's mine or his or anybody else's, to pass something, as we are going to pass a piece of our bill and a piece of these bills this week on dealing with Medicare. We're very proud of being participating in that, but we look forward to working with all of you on this.
Well, I want to thank both of you, and certainly going to take, your legislative initiatives in mind, and, as we move forward. That's what this is all about. And so I appreciate your coming today. Our practice is not to have questions of members, so I'm going to proceed. Thank you for being here. Really appreciate it. And we'll ask the next panel to come forward. Thank you both. Let me introduce the two of you. On my left is the Honorable Daniel Levinson, who's Inspector General, Office of the Inspector General, U.S. Department of Health and Human Services. And to my right is Dr. Peter Brudetti, who's Deputy Administrator for Program Integrity at the Center for Medicare and Medicaid Services, again with the U.S. Department of Health and Human Services. I want to welcome you. Thank you for being here today. We try to have you limit your comments to 5 minutes if possible, and then we'll take some questions. I'll start with Mr. Levinson.
Good morning, Chairman Pallone, Ranking Member Shimkus, and members of the subcommittee. Thank you for the opportunity to testify about those tools in the Affordable Care Act that will help to combat fraud, waste, and abuse in the Medicare and Medicaid programs. OIG has been leading the fight against healthcare fraud, waste, and abuse for more than 30 years in collaboration with the Department of Justice and our colleagues at CMS. Although there is no precise measure of healthcare fraud, we know that it is a serious problem demanding an aggressive response. Over the past fiscal year, OIG has opened over 1,300 healthcare fraud investigations and obtained over 500 convictions. OIG investigations also have resulted in nearly $3 billion in expected civil and criminal recoveries. Despite such successes, there is more to be done. Those intent on breaking the law are becoming more sophisticated and the schemes more difficult to detect. Fraud is migratory and adaptive. Criminals quickly modify and relocate their schemes to evade enforcement efforts. In response, the government is working to stay ahead of these schemes. Fraud will never be completely preventable, so we must investigate and prosecute fraud before the criminals and stolen funds disappear. New tools and resources provided in the Affordable Care Act will help us to do just that. My written testimony describes more fully how provisions in the Act will support the government's efforts. For example, OIG's work has demonstrated that it is too easy to obtain billing privileges and defraud the system. Anyone who wants to keep their home safe begins by doing something very simple, locking the front door. We need to do the same with Medicare. The Affordable Care Act strengthens the screening process to prevent criminals from enrolling as Medicare providers and suppliers. It also provides OIG new authority to respond to enrollment fraud. For example, entities that provide false information on an application to enroll or participate in a federal health care program are now subject to monetary penalties and exclusion from the federal health care programs. When criminals make it through the front door and suspected theft occurs, the Act's new payment suspension authority strengthened Medicare's ability to curb taxpayer losses. In addition, the Act authorizes longer prison terms and stiffer penalties for health care fraud. Put simply, criminals who commit health care fraud are going to be cut off from the Medicare trust funds faster, face longer prison terms, and be subject to larger criminal fines. The Act includes new transparency requirements that will shine light on financial relationships and potential conflicts of interest. Public disclosure of ties between drug and device manufacturers and physicians will help the government and the public monitor financial relationships and should deter kickbacks. The Act also requires nursing facilities to report ownership and control relationships. This will make it harder for unscrupulous corporate owners to avoid responsibility for substandard care in their nursing homes. The Act also empowers honest providers to do the right thing. Under the Act, providers and suppliers will adopt compliance programs that meet a core set of requirements. Well-designed compliance programs can be an effective tool for preventing fraud and abuse. OIG has provided compliance guidance to providers for more than a decade. We will also conduct compliance training programs for providers, compliance professionals, and attorneys across the country in 2011. The training will empower well-intentioned providers to identify fraud risk areas and best practices to avoid fraud schemes that may be targeting their communities. Finally, the Affordable Care Act provides new funding, $350 million over the next 10 years, that will expand and strengthen the government's program integrity efforts. Thank you for your support of OIG's mission, and I would be happy to answer your questions.
Thank you, Mr. Levinson. Dr. Berdetti.
Try that again. Chairman Pallone, Ranking Member Shimkus, Chairman Emeritus Dingell, and other distinguished members of the subcommittee. I am Peter Bedetti, and I'm privileged to hold the new position at the Centers for Medicare and Medicaid Services as the Deputy Administrator for Program Integrity, where I have the opportunity to address many of the issues that have been raised this morning. The Centers for Medicare and Medicaid Services are very pleased to have the new tools to fight fraud and reduce waste and abuse in the Medicare and Medicaid programs that were given to the Secretary and to the Department of Health and Human Services in the Affordable Care Act of this year, and I'm delighted to be here to discuss those with you. I'm very pleased to share this panel with my distinguished colleague in fighting healthcare fraud, the Honorable Dan Levinson, Inspector General of the Department of Health and Human Services. We are committed to enhancing the collaborative working relationship between CMS and the Office of the Inspector General, and I believe we have made significant progress in doing so since we embarked on this endeavor. On a personal note, I'm honored to be appearing before the subcommittee that I had the distinct privilege of serving as counsel for some 6 years. The Affordable Care Act is the most far-reaching health care law since the inception of Medicare and Medicaid. We greatly appreciate the new and expanded authorities and are excited about using the tools that Congress has provided to CMS in the Affordable Care Act. Most important with the implementation of these provisions that were provided by Congress is that CMS is looking, as many of you have mentioned this morning, to fundamentally shift our program integrity activities beyond pay and chase to fraud prevention. Even as we apply new technologies and methods to detecting and pursuing the fraudulent activities of dishonest or phony providers or suppliers, and as we continue our efforts to recover overpayments made for false claims, CMS is now focused on preventing either of these events from ever occurring in the first place. Our goal is to turn off the pipeline of fraudulent activity before it develops. We will do this in two ways: working with legitimate providers and suppliers to ensure compliance with program requirements, and taking new measures to keep dishonest ones out of the programs and to avoid paying fraudulent claims. Our fraud prevention initiatives stem from our first priority, which is to help provide our beneficiaries with the health care that they need. Precious public resources must not be diverted from that core purpose. To that end, working with states and law-abiding providers and suppliers to protect beneficiary access to needed health services, medicines, and supplies is the #1 goal of our program integrity work. With beneficiary interests in mind, as we continue the process of implementing these authorities and improving our program integrity, we must do so in a way that is fair and transparent to healthcare professionals, other providers, and suppliers who are our partners in caring for beneficiaries. Maintaining this partnership is an important aspect of our program integrity work. As we implement these new authorities, we have significant opportunity to build on our existing efforts to combat waste, fraud, and abuse. The new authorities offer more front-end protections to keep those who are intent on committing fraud out of the programs, and new tools for deterring wasteful and fiscally abusive practices, identifying and addressing fraudulent payment issues promptly, and ensuring the integrity of the Medicare and Medicaid programs. We also now have the flexibility to tailor our resources and activities in previously unavailable ways, which we believe will greatly support the effectiveness of our work. As an example of this, on September 17th, CMS posted a notice of proposed rulemaking that will implement several of the key anti-fraud authorities in the Affordable Care Act that go a long way towards enabling us to keep the bad actors out and to avoid paying fraudulent claims. This includes new measures to screen providers and suppliers before they're allowed into the program to bill the programs, new authorities to declare a temporary moratorium on enrollment for high-risk areas of fraud in our program, authority to suspend Medicare and Medicaid payments for providers and suppliers pending investigation of credible allegations of fraud. We look forward, since this is a proposed rule, we look forward to receiving comments and feedbacks back from all interested stakeholders and to working with the provider, supplier, beneficiary, law enforcement, and other key groups as we work to finalize this rule. This proposed rule builds on existing authorities and also on the rulemaking that we issued earlier this year that implemented the Affordable Care Act requirement for physicians and other professionals who order or refer Medicare covered items or services to be enrolled in the Medicare program. Healthcare fraud is a national problem. The loss of taxpayer dollars through waste, fraud, and abuse diverts those funds from supporting needed health care and drives up health care costs. Reversing this problem will require a sustained approach, brings together federal and state and local governments and law enforcement, beneficiaries, health care providers, and the private sector in a collaborative partnership relationship. This administration is strongly committed to minimizing waste, fraud, and abuse in federal health care programs. The President demonstrated this commitment with his executive order and setting a target to reduce improper payment rates in half by 2012, and we are committed to meeting the President's goal. The administration's made a firm commitment to reining in fraud and wasteful spending, and with the Affordable Care Act, we have more tools than ever to implement important and strategic changes. CMS thanks the Congress for providing us with these new authorities, and we look forward to working with you in the future as we continue to make improvements in protecting the integrity of federal health care programs and safeguarding taxpayer resources. Thank you, and I look forward to answering your questions.
Thank you both, and now we'll have some questions, and I'll start with by recognizing myself. In the health care reform bill, there is provision, to improve Medicare and Medicaid's fight against fraud, as both of you said in many different ways. But Dr. Bedetti, in your testimony, described the shift in fraud-fighting tactics that will come about as a result of these new approaches as moving away from pay and chase towards a more preventive approach. And of course, the hallmark of the healthcare reform is prevention. So I wanted to ask each of you, in Dr. Bedetti's case, what do you mean when you talk about shifting away from the pay and chase approach to reducing towards a more preventative approach?
Mr. Chairman, the two questions I've been asked most frequently since I took this position are the ones that I'm sure will come as no surprise to anyone, which is, why do you let those crooks in the program, and why do you pay them when their claims are fraudulent? And our approach to moving away from pay and chase recognizes the fact that we now have people getting into the program, billing the program, who disappear before they can be chased and who have no assets when we track them down. Pay and chase evolved from the core purpose of the Medicare and Medicaid programs, which was and is to provide services to beneficiaries, and to do that, we need to get providers into the program quickly, and we need to pay them promptly. But that speaks to legitimate providers and legitimate claims for the correct services. What we need to recognize now is that not everyone who's getting into the program and who is billing the program will be there when we chase after them. So moving from the traditional approach, which is always going to be necessary, to go beyond that to preventing the problems in the first place will mean two things in particular. Number one, keeping people out. And to do that, we're implementing new screening techniques, new screening measures. The Notice of Proposed Rulemaking that we just published speaks to this by putting providers and suppliers, following the terms of the statute, into different categories of risk and applying different levels of screening to different levels of risk. And that's an important step forward. And then in terms of not paying fraudulent claims, we're proposing to implement the new authority that allows us to withhold payments when there is a credible allegation of fraud, which we work closely with the Inspector General on determining what a credible allegation of fraud is. So moving beyond pay and chase, I should say, to preventing these problems in the first place is an important aspect of what we're doing now at the Centers for Medicare and Medicaid Services.
All right, let me ask Mr. Levinson, can you tell us about some of the benefits you expect to see when these provisions are put into effect?
Mr. Chairman, I think it's going to be especially helpful to strengthen the enrollment standards. As I said in my opening statement, to lock the front door. So much of the problem that we've experienced in so many parts of the country have to do with the ease with which historically you've been able to get a provider number. And I would only elaborate on Dr. Budetti's answer just by noting that my understanding is that historically, when the program was much smaller, simpler, perhaps the government even knew who it was doing business with, there was an emphasis on ensuring prompt payment to providers to make sure that doctors and others would want to participate in the Medicare program. And what's occurred over time is that the government has not kept pace with the enormous change, the explosion in size of the program, the increased sophistication of healthcare delivery and services. And certainly in the modern era, too often the government doesn't know who it's doing business with. And it has been an interesting experience for us in South Florida. Just to give you one example, in the year following our anti-fraud strike force work in the South Florida area, DME billing dropped $1.75 billion in South Florida alone, just by virtue of people getting the signal that the government was actually watching. So the strengthening of enrollment standards, it would be hard to exaggerate the importance that that will play, I think, in making sure that those masquerading as healthcare providers don't get in the program in the first place. It's not a panacea, and there are many other fraud, waste, and abuse issues that occur in other aspects of the system. But I would certainly emphasize first and foremost the importance of strengthening the enrollment standards that is included in the ACA.
Well, I appreciate this. I mean, I think, it's interesting because I always talk about prevention or preventative care in the context of healthcare reform. I hadn't thought about prevention in terms of the fraud aspect so much, but obviously that's really crucial, and so I'm glad to hear that, that what we're doing has a real potential to make a difference. So thank you both. Mr. Shimkus.
Thank you, Mr. Chairman, and I appreciate our panel today. It's a very important issue. Before I go into this, let me just, again, put on the record, 6-month anniversary, no Secretary Sebelius, no CMS Administrator Berwick, no CMS actuary to give us an analysis on the new health care law. We're more than willing to talk about the good and the bad, the good policies. Republicans are repeal and replace. Replace does talk about a lot of the positive things that went on through the law. But we still have to continue to make the point that we're 6 months into a new law without a hearing on the law. Maybe some specific provisions like this one, so that's why it's important. But this is our only venue. So, people have to understand. Other than that, or 1-minute speeches, or 5-minute speeches, or special orders, which is not really the venue for talking policy. So, I know my colleagues get frustrated, but it's we're just doing our job. This is a really great discussion, and it's a great discussion because it really highlights the healthcare debate in the aspect of. Let me just ask a simple question first. Will if we go after this this process and try to clean it up before the checks go out the door, do our admin costs go up? I'm just talking about the administrative costs to be able to have a cleaner system to protect the system for sending fraudulent checks out the door. Mr. Levinson?
Mr. Shimkus, I think you've put your finger on a very important question concerning the whole role of IT in being able to really master the system as opposed to simply respond to it. And our office will certainly be looking very closely as this more consolidated and integrated system actually unfolds over the course of the next year, the next 2 years. We've certainly been able to use real-time data just by coordinating better with CMS, with the Department of Justice, our strike force teams that have been operating in multiple cities now.
Well,
have been very
because my time's real short, but administrative costs going to go up. New IT programs, new surveillance. I mean, there is a higher cost for this on the admin side.
Mm-hmm.
Is that safe to say?
Well, I mean, from an audit side, and which is certainly part of our office, we will look back to see exactly how costs have been accounted for. But
we've got to change the way we're doing business now,
mm-hmm.
because we don't have the folks to audit on the front end. Dr. Videtti?
Thank you, Mr. Chairman.
It's not a trick question. I mean,
no, I understand.
Just trying to establish a premise here.
I think this is it's very important, I think, for us to keep in mind that the expenditures that have been made in over the years since the Healthcare Fraud and Abuse Control Program was established have been wise investments by the Congress.
But the question is, to clean up the system, is there more admin costs?
I'm not sure whether
here's my point.
But
okay. Let me.
Yes, sir.
I only have a minute left, 2 minutes left. But here's my point. In this whole healthcare debate, we've always demagogued the health insurance companies because they do what you want to get to. They have higher administrative costs, which is what's been demagogued for years here. Why do they have higher administrative costs? Because they're trying to make sure that the checks don't go out the door. We send the checks out the door, and then we take a 3 or 4 or 5 year process of trying to figure out who stole the money. So what we're saying in reforms here, and I'm with you, okay? We have to spend more money. We're going to have to update our IT. We have to have a process to stop the checks before they go out the door. And guess what? This is part of the opening statement. What's going to happen? And I agree. It's because we push prompt payment, and we want it early enrollment. We don't want anybody. Every time we spend money fast here, we whether it's Iraq, whether it's Katrina, anytime we're throwing money at a problem, we find fraud and abuse. So we want to have a quick response to get people their money because it's a fee-for-service system. But how we responded. We may end up withholding payments until we have an idea of whether. That's what happens now in the insurance industry. And people are frustrated to the heck because they're saying, oh, those evil insurance, I can't get my payment. Well, they're doing that to make sure that. So now part of our reforms will probably take some of the practices that the profitable evil insurance companies are doing and roll it into government services to make sure we're not ripped off. So that's my takeaway. I think it's important to do. My time's expired, Mr. Chairman, and I yield back.
Thank you. Chairman Dingell?
Thank you, Mr. Chairman. Gentlemen, we appreciate your testimony here. These questions relate to funding to fight fraud. The Affordable Care Act increased mandatory funding for the Healthcare Fraud and Abuse Control Fund by $300 million and indexed the funding for the Healthcare Fraud and Abuse Control Funds and the Medicare and Medicaid integrity programs to make sure it keeps up with inflation. Overall funding to fight fraud will increase by about $500 million over the next decade. Gentlemen, can you each discuss the need for the increased funding to fight fraud, and can you give us some examples of how you will spend these new resources?
Mr. Dingell, it has been exceedingly helpful to see a rise in funding for the healthcare fraud, anti-fraud control program after many years of essentially plateau expenditures for this vital program that really partners our office with the Department of Justice and with CMS to fight healthcare fraud in both the Medicare and the Medicaid program.
Where will you be able to spend these additional funds, and what benefit will that occur to the public?
Some of the dollars we're looking to enhance and expand the strike force operations, some of which you actually spoke to in your statement earlier this morning in Detroit. The July strike force operations, just to give an example, resulted in 94 indictments in 5 cities, including Detroit, that involved $250 million in false billing for DME, home health, infusion, physical and occupational therapy. These strike force operations require resources. They require resources at the investigative end.
Which they have not had till now.
Well, as the programs have expanded over the course of the last 10 or 15 years, and Congress was well aware of the need to structure a program to fight healthcare fraud when in the mid-1990s, as part of HIPAA, the healthcare fraud account was established. That account simply did not take into account, if you will, the explosion of dollars, the much larger programs that we've seen since the mid-1990s. So this is an important both catch-up to be able to devote resources on both the investigative and prosecutorial end, as well as take into account the added cost of being able to handle this in a sophisticated, technologically savvy way that the 21st century really requires.
Thank you. Dr. Bedetti, what comments do you have, sir?
Yes, Chairman Dingell. We're going to be spending this. We're very grateful to the Congress for making this investment in fighting fraud. This is an important step forward, an important increment over the monies that were already scheduled to be in the Healthcare Fraud and Abuse Control Program. We're going to be spending it responsibly to improve our enrollment and screening activities and processes, to consolidate many of our contracting activities. We're going to be coordinating Medicare and Medicaid policies to the maximum extent that we can, and we will be implementing many of the advanced data and analytic techniques that have been discussed this morning, as well as improving our data system. So we view this as an important step forward in terms of being able to support the kinds of activities it'll take to move beyond pay and chase to prevention.
Thank you, Doctor. Now, Mr. Levinson, it allows the Inspector General to exclude affiliates and officers of affiliates if a parent or sister company of the affiliate has been found guilty of healthcare fraud. What advantage is this going to confer on you and the taxpayers, and why is it necessary?
Mr. Dingell, it has been problematic for us to be able to actually pursue those who have engaged in wrongdoing, in defrauding the system. It has been simply too easy for corporate officials to simply resign, to leave their corporate office. The laws right now are in the present tense, so that the ability to exclude those found to have defrauded the system only work when they actually stay in place. Or once they leave, we're not really able to pursue them. The ability to actually exclude and go beyond any particular corporate entity allows us, in effect, to pursue those who actually have engaged in the defrauding of the program, and therefore will strengthen our ability to actually capture the people who have taken advantage of it.
Thank you. Just do this, would you please? Submit to the committee about other legislative changes or additions that you, in your agency, and you, Dr. Bedetti, need to address the problems of fraud. For example, piercing the corporate veil of subsidiaries or affiliate companies, being able to seize assets of these corporations, being able to address the officers as opposed to just the corporation, because getting the officers makes pain where it is most necessary and most needed. So if you would submit that to the record, I would appreciate it. Mr. Chairman, I thank you for your courtesy to me.
Mr. Dingle, you asked them to follow up with some written comments. I didn't hear you. Absolutely. Any member who wishes to do so. The gentleman from Georgia, Mr. Gingrey.
Mr. Chairman, thank you. I think we can all agree that there's no room for waste, fraud, and abuse in the Medicare program, and it puts taxpayers' dollars at risk. It jeopardizes the integrity of our seniors' health care program. However, it seems that President Obama and the Democratic majority have a different view about what constitutes waste, fraud, and abuse. On July the 30th, 2009, President Obama promised that the health plan was funded by eliminating, and I quote, this is his quote, the waste that is being paid for out of the Medicare Trust Fund. And then on September the 10th, 2009, Speaker Pelosi said that Congress will pay for half of Obamacare by, quote, squeezing Medicare and Medicaid to wring out waste, fraud, and abuse. I want to ask the Inspector General, Mr. Levinson, do you feel that the $137 billion cut in Medicare Advantage in the bill is rooting out waste and combating fraud in the Medicare fund?
Mr. Gingrey, that's beyond my portfolio to opine on.
Let me ask you to opine on one other then. The CMS actuary says those cuts will cause 7.5 million seniors to lose their Medicare plan by 2017, and the benefit reductions that will result are expected to cost seniors, on average, $250 in extra cost per month. Is charging seniors $250 more a month on average for their Medicare ending waste or combating fraud?
I would be happy to defer to Dr. Budetti if he wants to answer that question.
Well, let's let you do that. I'll be happy to seek a response from Dr. Budetti on that particular question.
I believe that's comments by the actuary are also not part of my portfolio.
All right. Well, let me shift back to Mr. Levinson then. Hospital reimbursement for Medicare seniors are being slashed by $155 billion. This is to the hospital. CMS actuary projected that those cuts could drive about 15% of the hospitals and other institutions into the red and jeopardizing access to care for seniors. Is slashing hospital payments to the point where you threaten their ability to stay open, and you're threatening seniors' ability to be able to find one that will treat them? Is this ending waste or combating fraud? Either Mr. Levinson or Dr. Budetti.
Well, speaking to our efforts to reduce waste and combat fraud, sir, we have, I mentioned in my opening remarks that our core commitment is to our beneficiaries. And to do that, we need to have the legitimate providers and suppliers in the system as partners with us. We need to work with them, and we need to support them. So our approach at our end of the spectrum, working on the fraud and waste and abuse, is certainly to keep in mind the critical importance of beneficiary access, and the fact that
I understand my time is limited. I'll ask one more question, and I'll just ask it rhetorically because I understand what the answer would be from both Mr. Levinson and Dr. Bedetti. The President, Speaker Pelosi, also slashed billions of dollars for home health care and hospice. Hospice, as you know, is provided to patients in the last 6 months of their life, those who are suffering in many cases from metastatic cancer. These cuts threaten the quality of health care for patients in the last stages of their lives. And again, I would ask the question, in your opinion, is cutting hospice payments, ending waste, or combating fraud in the Medicare program? And our witnesses have already said to the previous questions, this is not really in their jurisdiction. But, Mr. Levinson, it is, this question, I think, is in your jurisdiction. These 30 provisions in Obamacare, the result in $6 billion, and this is the Congressional Budget Office estimate, not mine, $6 billion in savings over 10 years. That's about 0.5%. And we're estimating here that we're wasting $68 billion a year. In fact, the FBI says it's $226 billion a year. We've got 30 provisions in the bill that save $6 billion. Mr. Levinson, didn't you make recommendations to the Senate Finance Committee and indeed maybe even to this Committee on Energy and Commerce regarding the bill as it was being developed, a lot more recommendations in regard to cutting waste, fraud, and abuse that would amount to much more than $6 billion a year in savings? And why weren't they included in the bill?
Mr. Gingrey, it is certainly true that our office has provided technical assistance to both the House and the Senate over the course of the last year and a half as the legislation went through. And that is a very important part of our job. We report to the Secretary, but we also report to the Congress. And we endeavor to try to provide the best technical assistance. That assistance was directed towards the healthcare fraud provisions, Title VI mostly, although perhaps not entirely. I think there might be elements in other titles, but primarily Title VI title assistance. And it was a matter of responding to member requests on how to handle, how to phrase, how to craft particular initiatives. And if there are added questions from Congress, and certainly we will be looking at how the law unfolds over the course of the next couple of years, much as we did with MMA when it was passed in 2003. Our office has done significant work on Part D to try to understand where the possible problems are there. We will certainly be doing the same with the Affordable Care.
Mr. Chairman, as I yield back, I realize I've gone beyond my time, and I thank you for your patience. If I could request that Mr. Levinson would submit his annual recommendations in combating waste, fraud, and abuse to the committee, I would appreciate that for the record.
Is that something that's already out? Okay, thank you.
Thank you. I yield back.
We ask you to do so. Chairman Waxman.
Thank you, Mr. Chairman. The Affordable Care Act included a series of program integrity provisions that CBO estimates will save federal taxpayers $6 billion over the next 10 years. The Act provides CMS and the Inspector General with dozens of new tools to prevent fraud and keep fraudulent providers out of Medicare and Medicaid. It has new civil and criminal penalties. It has new data sharing requirements, and it provides $500 million in new funding to fight fraud. Dr. Bedetti, some have called for repealing the Affordable Care Act. What effect would repeal have on your agency's ability to detect, stop, and prosecute fraud against Medicare and Medicaid?
Mr. Chairman, the Affordable Care Act has so many strong provisions in it that are the central part of our initiative to move forward to keep people out of the program who don't belong in the program and to avoid paying claims that are fraudulent. It also provides the support for us to do that.
Keep people out of the program? Are you talking about beneficiaries or providers?
To keep fraudsters out of the program, to keep scam artists, to keep people who would enter the program simply to be able to submit bills and not provide legitimate services, to keep those people, the bad guys, out of the program. And the Affordable Care Act provides us new and expanded authorities that are absolutely central to our ability to do that going forward. It also provides the increased financial support that's important to us. It provides a new level of flexibility in how we go about this so that we can be nimble and adapt to the changing problems that we see all the time. These are very important provisions in terms of the ability to protect Medicare and Medicaid resources, Mr. Chairman.
Well, some have called for repealing the Act, but others have called for defunding the agencies that implement the Affordable Care Act. What effect would defunding have on your CMS's ability to fight fraud?
The activities that we're doing to implement the Affordable Care Act, the new provisions, are on top of a very, very large array of activities that have been going on for some time. All of those are demanding on staff and on our resources. Any serious limitations in our ability to carry out these programs would mean that the likelihood of getting a return on investment would go down. The less we invest in fighting fraud, the less of a return on that investment that we would see over time.
Mr. Levinson, what is your view? Would eliminating and defunding this new anti-fraud provisions in the health care reform bill impact the work of the Inspector General to reduce fraud?
Mr. Chairman, that is beyond my portfolio to opine on. We take the law as passed by Congress, and we try to make the laws most effective. And
well, if you didn't have this law, do you think that your anti-fraud efforts or the department's anti-fraud efforts would be weakened?
Well, we think that many of the provisions, especially in Title VI, that strengthen the enrollment standards are very helpful in being able to create much greater controls over the program so that fraudsters are not able to gain entry. We think that mandating compliance programs, which also is included in the Act, will be very helpful in getting so many of the lawful providers the kind of assistance and the kind of incentives to structure their programs so that they are not either advertently or inadvertently in violation of Medicare, Medicaid rules and guidance. So unquestionably, there are many features of this Act that I included in my opening statement that are very beneficial to ensuring that the programs will run with far less exposure to fraud, waste, and abuse.
Thank you. Mr. Chairman, there are plenty of good reasons why repealing the Affordable Care Act is a terrible idea, including the fact that repeal would increase Medicare and Medicaid fraud. And I just want to make that statement very clear, because when we hear people on the other side of the aisle complain they don't like the Act, they want to repeal it, they want to stop the agency from getting funded, what they're in effect saying as it relates to today's hearing is that they are going to increase Medicare and Medicaid fraud when the policemen on the beat, which is the department, and others in this area are not given the tools to fight fraud and abuse. I think it's clear that fraud and abuse will be increased rather than decreased. Yield back to balance my time.
Thank you, Mr. Chairman. Next is gentleman from Texas, Mr. Burgess.
Thank you, Mr. Chairman. Just in reference to the chairman of the full committee's remarks, I would submit that the bill itself is a fraud that's been perpetrated on the American people, but it is what it is, and we've got to make the best of it. So the Patient Protection Affordable Care Act predicts a drastic cost savings from fraud prevention to cover the $500 billion in cuts to Medicare, as well as allocating $10 billion annually for the fiscal years 2011 through 2020. The Reconciliation Act that was passed right after the bill provides an additional $250 million for the period 2011 through 2016 for healthcare fraud and abuse program. In order to combat fraud and use the money in the most effective manner, do you think, and I'll actually address this question to either or both of you, in order to combat fraud and use the money in the most effective manner, do you believe it would be beneficial to hire more federal prosecutors, as I referenced in my opening statement, with a background in healthcare fraud to combat this problem as opposed to hiring prosecutors with no previous healthcare experience.
Mr. Burgess, we've had over the course of years, a very, very good and productive relationship with the Department of Justice, the Civil Division, the Criminal Division, United States attorneys in all 94 districts. Unquestionably, I think there is more focus on healthcare fraud in some parts of the country and in some districts than in others. We certainly want to encourage as much expertise to be embedded in the Department of Justice as possible. We know that they rely upon the expertise of our investigators, our agents, for a lot of the work that we do, as well as the FBI.
I don't mean to interrupt, but we had this discussion, of course, last week as well. And in my area, in Texas, in the North Texas area, I asked people from HHS, Office of Inspector General, as well as Department of Justice, to come and talk to me about some of the problems we were having with foreign nationals who were setting up sham operations and literally just ripping the government off. The figure I reported over $8 million from one individual who's now in jail, thankfully. But I was told by both your folks in the Office of Inspector General and as well as the Department of Justice that they lacked the prosecutorial manpower to go after. In fact, there were certain levels where they wouldn't even bother to bring a case, and I forget what the level was, but I was startled by the size of the number. And yeah, I recognize that terrorism is important, and I recognize that there are lots of other places we need to spend our money, but this is important as well.
Absolutely, and I'm not trying to dodge the question. The question really is best posed in the first instance to the Justice Department because they're the ones who need to take responsibility for their resources. I can say, though, clearly that it's a testament to how hand in glove we work with our partners at DOJ, that you can meet with folks from both of these departments and get whatever picture they are giving you about your neighborhood and what's going on and what needs to be done. And it's absolutely true that no matter how many investigators you have, if you don't have the prosecutorial backup, then you have cases that are simply lingering. That you're really not doing enough for the system.
Yeah, and you referenced in your opening statement about you had to lock the front door. We go after a lot of this stuff, sort of a post-payment review. And the figure I have here that fewer of 700 of the 8.7 million claims were reviewed. That's a pretty small number. Is there any way to prospectively? We never hear of Aetna, United Healthcare, Blue Cross Blue Shield having these same types of problems. Sure, there's probably inappropriate utilization in those with those payers as well, but it's never to the order of magnitude that it is with the public programs. Is there a way to do it prospectively?
Mr. Burgess, I think that the National Healthcare Anti-Fraud Association, those who actually deal with anti-fraud efforts in the private sector, might be able to provide some useful detail on what's going on the other side of the ledger. And healthcare indeed is a hybrid system in the country where you have both robust private and public sector involvement. We deal at the IG's office with the system that we have, and we certainly try to encourage our partners in the department to try to clarify and make more transparent what's going on so that we can do our job better, and indeed they can do their job better.
But that figure of 10%, you just think of any company, any private company, publicly held company in this country that had a 10% loss rate due to theft would certainly try to get its arms around that. It's two things that do concern me, the anti-kickback statute and the health provisions of the criminal mail fraud statute, concerned that we may turn innocent coding errors into federal cases. What are you doing to kind of protect what may be simply an innocent mistake from someone who's then receives the full force of the federal prosecutorial force on their doorstep?
Yes, that's a very important question, and indeed, I think just looking at the improper payment problem is kind of a good macro example of what we're talking about, because the programs do suffer from a lot of improper payments. And in many cases that has to do with documentation that for one reason or another is not fully exposed on the record. It simply is a failure of documentation. That might be hiding fraud. But in many cases, probably in most cases, it isn't. There is something else going on. There is still a failure to document, but improper payment does not equate with fraud, and proper payment doesn't equate with lack of fraud. It's very possible to get the payment system looking right, and indeed what it's doing is it's masquerading some fraudulent scheme. So when it comes to healthcare and some of the sophisticated kinds of scams that are occurring, it really requires an information technology system and the cooperation of a lot of different parties to be able to tease out the kinds of very serious issues that you are raising and that need to be done as a result, certainly of the added dollars that are being provided now for health IT. Those dollars need to be focused in significant part, I would, in my opinion, on making sure that we don't fall into those kinds of problems where you do have genuine providers who are then being questioned on a very fair record because we have gotten the IT piece wrong.
We're over time here. Thank you. Next is gentlewoman from Florida, Ms. Castor.
Thank you, Chairman Pallone, very much. Dr. Bedetti, on October 1st, the private health insurance companies will begin to market to seniors all across the country for private Medicare plans. I've been concerned for many years about some of the marketing practices and have direct experience with this, with some insurance companies sending agents to assisted living facilities or nursing homes to try to sign up seniors. Oftentimes, if they were on traditional Medicare, they'd lose access to their trusted doctor. I've seen them camped out in front of senior apartment complexes to try to get them to sign up and use high-pressure sales tactics. The problem is, a few years ago, the Medicare Modernization Act took away the authority of our state insurance commissioners to go after these fraudulent practices. So now the burden is wholly on HHS and the federal government. In the House version of the health reform bill, I had an amendment. It was a bill I had to restore the authority of our state insurance commissioners and consumer advocates to go after those practices. And that didn't make it in the final package, unfortunately, but these abusive tactics remain, and I'm very concerned because they prey on seniors that often lack the wherewithal to withstand the high-pressure tactics or may suffer from dementia or Alzheimer's. And what can you do? What tools do you have where you can work with the states to make sure that you're taking action against those type of marketers? And I really want to understand what you can do, what authorities you have, what else do you need? Obviously, we've got to return some authority to the state insurance commissioners. Consumer advocates are strongly behind this proposal. But in the meantime, until we do that, what can you do to work with states to make sure we're going after those folks?
Thank you for that observation and question. One of our priorities at the Center for Program Integrity has been to expand our work with beneficiaries to help them become really partners in spotting and preventing scams from occurring in the first place. We're working closely with the Administration on Aging to expand the Senior Medicare Patrol, which is trained seniors to review their Medicare statements. We have been rewriting those Medicare summary notices so that they are more user-friendly. We've been encouraging people to use My Medicare system so that they can review their claims right on a immediately up-to-date basis. And we've had a lot of outreach and consumer education that we've been doing. I think you're aware that we've been holding regional fraud prevention summits around the country. We held one in South Florida, the first one in South Florida. And in fact, at that summit, we held a major piece of it was to work with beneficiaries and to interact with beneficiaries on how they could help in preventing and fighting fraud. So one major aspect of what we're doing is to get the beneficiary community more aware and give them more tools to work on this. In South Florida, in fact, we have established a separate hotline specifically for that purpose because of the problems that we've seen, but also because we are promoting the awareness down there. So beneficiary outreach and involvement in education is a very big piece of what we're doing. We also, of course, have our oversight of the Medicare, the Part C Medicare Advantage plans, and we do have our responsibilities to oversee them and to look closely at whether they are complying with the requirements that are imposed on them, and also with respect to the way that their funding is working.
Mr. Levinson, do you have a comment? And what happens if someone gets caught, if a company gets caught with these high-pressure tactics or coming into a nursing home when they're not allowed? What's the penalty?
Well, I wouldn't want to speculate, I'll put it that way, Ms. Castro, on exactly what would happen, given that we have 400 investigators who really follow up very conscientiously on healthcare fraud allegations of a wide variety. And depending upon the particular facts of what happened, there can be very serious penalties.
I just think that this should be a shared responsibility, that our states have additional tools that can help protect seniors from these high-pressure tactics that often result in seniors not being able to see their own doctor. And under the Medicare Advantage plan, oftentimes you're signed up, you can't get back out. It's a pain to try, if there's been some fraud committed, to actually switch back out of a private plan back to the coverage you had. On the
yeah, I have to ask the gentlewoman. We're at a minute over.
Okay, thank you.
So, thank you. The gentlewoman from the Virgin Islands, Ms. Christensen.
Thank you, Mr. Chairman, and thank you, Dr. Bidetti and Mr. Levinson. Dr. Bidetti, CMS is requiring providers to enroll in the provider enrollment chain and ownership system. And the deadline is effectively passed, although you haven't started rejecting the claims. In your testimony, you say that over 800,000 providers have enrolled. Do you have any idea how many of those are minorities, or how well those practicing in poor or rural areas are represented? Many minority doctors, for example, practice in poor communities, and Medicare and Medicaid make up a large part of their patients' payment form. So what special outreach, if any, has been done or is being planned, and do you plan to track enrollees by racial, ethnic, geographical, or any other data? The Affordable Care Act has placed a lot of emphasis on diversifying our workforce, reaching out to underrepresented minorities, and making sure that the programs reach rural areas.
Dr. Christensen, I'm not aware that we have any data on the backgrounds, demographic backgrounds of the enrollees to that extent. I do know that we are making major efforts to conduct outreach to all the providers who are required to enroll, and to improve our systems to be able to handle the enrollments more efficiently. And I'll be delighted to look into that issue and see whether there's an opportunity for us to do exactly what you suggest.
Yeah, my office will be working with NMA and some of the other organizations to try to make sure that they understand some of the provisions and are able to take advantage of the benefits. Dr. Levinson, as a physician who acted with pharmaceutical reps during my practice, although it was a while ago, I'm interested to know what would be considered a transfer of value. Sample meds, which we use to help poor people get through their medication, pens, simple trinkets, CMEs with a meal. None of those really influence me, and I'm sure don't influence the majority of providers who are really just trying to do what's best for their patients and help them to get a better health outcome. What do you think would be considered a transfer of value, which is required to be reported under Section 6002?
I would respectfully ask that my counsel provide you a legal definition. And I say that in part because some of the examples that you were alluding to, based on your own practice and experience, don't strike me as the kinds of things that are actually being targeted by that law. So I think it would be helpful to get not my off the top of my head definition of that, but for you to get our counsel's explanation of what exactly that includes.
Thank you. And I guess, Mr. Bedetti, you talked a little about the outreach to beneficiaries. And I remember beneficiaries getting their notices of information from Medicare and coming in and my having to sit down and interpret them for them. Again, you have a lot of people who don't have a lot of education, worked in low-level jobs, who are now Medicare beneficiaries and are going to have a lot of difficulty not only understanding the information that's sent out, but even going through their bills. And they have such an important role to play along with both of your offices in the Department of Justice. So how do you plan to help these beneficiaries understand what it is, what their role is, and how do you plan to reach them?
Dr. Christensen, when I first started thinking about how we were going to go about this, I asked my colleagues if any of them had tried to read their explanation of benefits recently. And
it hasn't changed.
And I was reassured that that was a challenging task, to put it mildly. So one of the first things that we did was to start working with Medicare beneficiaries to have focus groups and specifically work with them on how to make the Medicare summary notices more user-friendly and more readable. And also, we also want to highlight in the summary notices what we're looking for, what we want them to look for by way of potential problems. So we're working on it on that end to try to get the documents that we are sending to them to be more usable. But we're also working, as I mentioned, with the programs that are in place, the Senior Medicare Patrol, who are educate beneficiaries, and it's a train-the-trainer approach where they will go out. So we're addressing this, I think, on two fronts, and I'm optimistic that this will pay off.
Thank you. Thank you for your answers. Thank you, Mr. Chairman.
Gentleman from Maryland, Mr. Sarbanes.
Thank you, Mr. Chairman. There's a good piece of legislation on the floor today, H.R. 6130, the Strengthening Medicare Anti-Fraud Measures Act of 2010, which will give you all some additional tools in terms of combating fraud. In particular, this would provide more clarity on the rules for excluding individuals and companies from the program based on findings of fraud and associations they have with companies that have been fraudulent. And I just wanted to make sure, for the record, I assume you all are very supportive of this additional set of tools.
Mr. Sarbanes, we don't explicitly endorse bills, but I do want to note that 6130 closes a statutory loophole that allows corporate officials to escape liability simply by resigning their job. And current law is written in the present tense, so an executive of a corporation that engaged in criminal fraud can evade exclusion simply by resigning before the corporation is convicted. And 6130 would hold responsible those individuals that are ultimately in charge of the corporations that defraud the healthcare programs and taxpayers. The legislation would also help end the shell game in which large corporations resolve criminal liability by pleading guilty through a shell subsidiary. Under current law, if a single entity within a chain of entities is sanctioned, our office can exclude the sanctioned entity's subsidiaries, but cannot exclude its parent or sister corporations, regardless of whether the related entities are operated or owned by the same people. So by reaching affiliated entities, the legislation will provide new incentives to corporations to promote compliance and police the activities within their corporate families.
Great. Thank you for those comments. Let me ask you this question. There was a discussion about administrative overhead, and I assume that when it comes to combating fraud, both prevention measures would be part of administrative overhead, as well as the pay and chase, or really, I guess, the chase element of it, right, is going to be counted as administrative overhead, would it not?
I think that's an important consideration, Mr. Sarbanes, that we have to take a look at the entire spectrum of what it will take, on the one hand, to implement these provisions, and on the other hand, where the savings will be in terms of things that we might not have to do down the road.
So it's conceivable that the administrative cost, the net administrative cost, could go down if you're more effective in the prevention side of things and have to spend less money chasing folks after they've been paid. That's, I guess, the point I was making. The other thing was Congressman Shimkus raised an interesting point, which is, you know, comparing the overhead and administrative costs on the private side with the public side, Medicare, and, you know, noted that there's sort of the evilness of the insurance companies in terms of their administrative costs is often pointed to by the critics of the way the insurance companies operate. My own sense, and I'm not asking you to necessarily respond to this, but my own sense is that it's not so, the evilness is not so much that they've got good warranted prevention efforts on the front end that may add something to their administrative costs. It's that with respect to providers that have already been vetted and are providing legitimate services and are legitimate providers, that there's a whole part of the operation that's dedicated to denying payment and wearing those folks down, and that actually consumes a tremendous amount of administrative costs that don't have to be part of the equation. I'm going to run out of time in about a minute, so let me ask you something else. What amount of the fraud would you say is attributable, to the extent you can quantify it at all, to providers that are just completely non-existent? In other words, it's just a paper provider, right, who managed to get hold of a provider number and has figured out a way to completely create out of whole cloth the documentation and other things that get submitted to be paid, versus, and in that case you're talking about harming the system and harming beneficiaries in an indirect way, in that huge amount of dollars that could be going for legitimate services are going to non-existent providers. So there's that category of fraud and abuse, versus situations where the provider exists, but they've really set up shop to push through services that are unnecessary, in which case you're talking about a direct effect on the patient as a result of that fraudulent activity, because they're being put through tests and other things that they don't need. Do you have any sense of kind of the percentage in each of those areas? Or
quite honestly, Mr. Sarbanes, I cannot give you percentages. Healthcare fraud is perpetrated on the street, in corporate 500 offices, by doctors, by pharmacies, by beneficiaries. But of course, the great majority of all of those categories are not engaging in healthcare fraud, but we see it pop up in such a wide variety of contexts. It's rather difficult to be able to sort out, given that.
Well, I'm out of time.
But I just would like to finish by noting that when, and I made allusion to this earlier, during the year after our strike force work in South Florida, DME billing went down by 63%. And it is so crucial to get control of enrollment, because enrollment fraud is the kind of problem where people masquerading as healthcare providers are getting into the program. Take care of the enrollment issue, and unquestionably you have resolved a certainly important percentage. I can't give you the number, but a significant problem has been eliminated.
Thank you.
Thank you. Let me thank both of you. I mean, obviously, this has been very helpful to us.
Mr. Chairman,
Oh, sure.
just before
Yield
you
to the
close,
gentleman.
I have this has been vetted to the majority, another letter in support of Peter Robson's bill. If we could submit that for the record, I appreciate it.
Without objection, so ordered. I just wanted to thank you because I think this has been very helpful, not only in terms of what you're doing under the healthcare reform bill, but other ideas that might be useful. We had the two members of Congress testify before, and they have some legislation. I guess Ron Klein's or part of it is actually on the floor today. That's what Mr. Sarbanes was talking about. So, this is helpful to us as we move forward. Thank you very much. Now, as you notice, some members had asked some questions, and you may get additional ones within the next 10 days, and we'd ask you to try to get back to us with a response as soon as possible. But without any
Thank you, Mr. Chairman.
other objection, this hearing of the subcommittee is adjourned.
Eating right makes a big difference. It can make a fast guy faster and a slow guy, slimmer. PetSmart carries more natural food solutions than ever. And now we offer wellness with healthy, natural ingredients your pet will love. You could say that food matters, but that would be an understatement. PetSmart, we love to see healthy, happy pets. With wellness natural pet foods, every ingredient has a purpose, trusted to become the foundation of your pet's well-being. Now available at PetSmart.
Fact. When doctors are in pain, the medicine in Advil is their #1 choice for pain relief. More than the medicines in Tylenol or Aleve. Use the medicine doctors use for themselves. One more reason to make Advil your #1 choice.
Well, are you going to pick it or not? It's not ready yet.
Tim and Richard Smucker grew up learning that you have to pick fruit at the peak of perfection if you want jam to taste extra delicious.
It's getting close.
For 5 generations, with a name like Smucker's, it has to be good.
Okay. We wanted to make this next package all about one emotion. Now, at first we thought boredom, but that's no fun. Depression, too depressing. Ennui, too French. They love French jokes. Instead, here's one we know you're going to be excited about. It's a package about excitement!
Where are we?
I don't know. Maybe Mommy can tell you.
Hang on, let me park the car. Cameron, I have something to tell you.
Cameron,
Don't
Don't get upset. Look at Mommy.
What?
Look at Mommy. We're not at Myrtle Beach. We're at Disney! We're at Disney!
We're at Disney!
Charles. Oh, please.
Show it to me.
And now that he's got that video game, this is probably the last exercise he'll get. Good opera singers aren't born, they're discovered, hiding in their rooms.